Cataract and pterygium is, I'm not sure how common it is in our practice. I don't see that common here in Kerala, but then yes, outside our state, in the southern states, it's quite common. One of the reasons probably maybe, both has got a kind of same etiology. UV irradiation has been blamed for both. So like any lesion in the cornea or on the cornea, ideal situation when pterygium exists is to have a staged procedure. You do a pterygium surgery, let the cornea settle, and then go ahead with the cataract surgery. Now, when we are faced with this combined problem, at times, or probably most of the times, you think about the combined surgery because in older patients, you just need to get over the whole thing in one sitting. The advantage is faster visual rehabilitation, fewer hospital visits, and of course, because you are avoiding two surgery, the cost is much less. So when can you consider? Probably in small asymptomatic pterygia, you can think about a combined surgery. Now, when we are faced with a patient having both the problems, the questions that we should ask ourselves is, what is the change that is going to happen after the pterygium surgery? Can pterygium surgery or the pterygium itself affect the biometry, the IOL calculation? If it affects, how and to what extent? And if you're thinking about a stage surgery, how far out after the first surgery can you think about your cataract surgery? Now, it is well known that pterygium affects central K, central keratometry. What does it cause? It causes the flattening of the horizontal meridian, basically because of the altered tear film on the surface. And it is known that combined cataract with pterygium surgery causes a myopic shift. So, what is the astigmatic change that is happening after you remove the pterygium? There is a steepening. If the pterygium size is less than 2 millimeter, the steepening is supposed to be around 0.15 diopters, and if it is more than that, depending upon the size of the pterygium, it can go up to 1.5 diopter. And it has been shown that the IOL power correlates negatively with the cornea because of the steepening. And this change in K happens mainly in the horizontal meridian, and it correlates with the, as I mentioned, not just the length of the pterygium, but the area the pterygium covers. So it has been shown that there is a significant, moderate, and positive correlation between biometry and the pterygium length and area in various studies. They have, shown that between 2.4 to 4 millimeter extension of the pterygium into the cornea, or if the area is more than 5.45 millimeter square, there is a 0.5 diopter change in power. You have to anticipate that in your biometry. If it is less than that, you can just go ahead and do the pterygium without thinking much about what is going to happen after the pterygium surgery, because it doesn't really produce any effect on the central K. 2.4 to 4 millimeter, they say probably you should think about undercorrecting the IOL power by 0.5 millimeter, 0.5 diopter. And if the pterygium size is more than 4 millimeter, it is always staged, because it comes into the area where almost all machines measure the K. So staged is preferred here. Then comes the question of timing of the surgery. Practically no consensus here. So when does the cornea stabilize after pterygium? It probably is related to the size of the pterygia. Majority of them stabilizes within 1 month of the surgery. And this study, they have shown that if the anterior or the advancing edge is between 1/3 diameter of the cornea and the pupillary margin, it takes about 3 months for the cornea to stabilize. And if it is more than thus extending onto the pupillary area, probably it is a good idea to wait for 6 to 12 months after your pterygium surgery before you do the cataract surgery. So the recommendations, probably if If the patient is really asymptomatic, it doesn't really matter what the size or stage of pterygia is. You can just consider cataract surgery alone. If it is more than 2 millimeter, the biometry is still valid. You can combine or not combine based on your comfort and the patient's symptoms. If it is between 2 and 4 millimeter, if you are thinking of a combined surgery, probably you should undercorrect your IOL by 0.5 diopters. And if it is more than 4, always think about stage surgery. And these recommendations are basically mine. So it's more of, eminence based rather than evidence based. But yes, these are just a few simple guidelines where you can start. Thank you.